A very good morning to all of you and welcome to the GMO Academic Cow program. Today we mark the final lecture for this year and we are happy to announce that we have completed 20 lectures during this year. So today we have invited a very special lecturer who is none other than the GMOA president, consultant neurologist attached to North Colombo Teaching Hospital, Ragama, Dr. Darshana Sirisena. So today's lecture is on Parkinsonism. Are we doing enough? So if you have any questions related to this topic, Parkinsonism, please send them over through the chat box and we are ready to answer those questions at the end of the lecture. So let me warmly welcome Dr. Darshana Sirisena to the Academic Cow program. Over to you, sir.
Thank you, Charuni. Good morning, a very good morning to all of you. And it's so pleasure to give this lecture and the last one for the year. So before the beginning of my talk, I just need to give some briefing because the academic cover and these academic activities was a brainchild of the GMO Executive Committee and the General Committee, which we decided about a year ago. Actually, we identified continuous updated knowledge is one of the most important thing to survive in today's context as a doctor. So therefore, we started our academic subcommittee, which was there before, we renewed it. So on top of that, we wanted our members to be armed with all the necessary information into day-to-day activities. Especially, I know majority of our doctors are practicing at the general practice level. So in that case, we were initially targeting lectures which are related to the clinical aspects of patient management. And not only that, then we had an array of lectures depending on the leadership qualities. As you know that the brain drain was an issue, so which forward we did many lectures on to accept of the IELTS and other things as well. So overall what I feel is we had a great success. So I need to thank many of the people at these as the last lecture and as the president of GMOA, the executive committee, all giving their full blessings on this one. So especially to Harita Ludge and the other members of the executive committee. And special thanks to my good friend Prasad Herath, Dr. Prasad Herath and Charuni Kolambage, who took all the hard work, all the effort to make this a success. And in fact, which had been a major success at the moment, we have delivered almost 20 lectures so far, which is with great numbers, though at the initially we have huge numbers, huge participation. But we saw over the last few weeks also few lectures, the numbers are going down, which shouldn't have happened. So I think we shouldn't have a good start for the next year. I'm sure we can start a new beginning from today. So the interesting thing I want to add, actually, we had a recently meeting with the how to couple these programs with the CPD activities or CPD accreditation. You might know the GMO academic activities has been recognized as a CPD provider at the moment. So therefore, we are already on there. So what is going to happen in the future with the association of the main CPD activities committee, I think I couldn't remember exact naming of that, with the Ministry of Health. In the very near future, we will be awarding CPD points. So with CPD points, so each and every member need to get the CPD point, and there may be so many incentives which we are planning for you, just to stimulate you to be updated about the knowledge in day-to-day practice. So I'm very much in positive mind, or I'm very much optimistic this CPD activities or the academic cow program will go from strength to strength from next year onwards. And once again, I thank all of you who have contributed to this program over the last 1 year program. So now I'm coming to my official talk, the activity today. So I'm going to discuss about, as you all aware about the talk, Parkinsonism, are we doing enough? So Parkinsonism is one thing very close to me since I started my senior registrar period in 2006. I was very fascinated about the Parkinsonism. Therefore, I had the opportunity, I was fortunate to follow a fellowship in Parkinsonism and other movement disorder at Monash University in Australia, which was actually an eye-opener to what we are doing and what are gaps we have with the international arena. So since then I returned, we have been doing a lot of things into improving the management and the patients who have Parkinsonism, which I will say you might be really why Parkinsonism, or I'll explain to you. So why I thought that are we doing enough? Sincerely, I think over my last 15 years experience as a consultant neurologist, we are not doing enough. We are barely doing enough. That's what I say. So we can do a lot of things, but unfortunately, due to the lack of knowledge, we are not doing enough. Okay, so to stimulate you at the beginning, I'll show you a video. What I want you to know is what I see. Just see whether, at your knowledge, whether this patient has Parkinson's or not. That's what I want to know. Secondly, what I want to know is, if you are thinking this patient has Parkinson's, why? Just don't say it's yes or no, it's 50-50 probability always. That's not good enough. So what I need to know is whether this patient has Parkinson's or not. If no, that's fine. If yes, why I am saying this patient has Parkinson's. So I'm not going to describe anything. Just look at the video and say whether this patient has Parkinsonism or not. I'm asking to do certain maneuvers which you need to understand whether it's normal or abnormal. Okay, I'll show it again once more for your interest. Okay, that's more than enough, right? Okay, we'll go to the right. So during my talk, I'm going to cover up 3 areas. One thing is a very brief introduction. Secondly, the most important part of this talk would be the diagnosis of Parkinsonism, right? So that is where we are lacking, we are behind. You will understand during the talk what an easy diagnosis we are missing. Thirdly, just a very brief idea about management principles. I'm not going to talk in length about the management, very much on the very little area on management principles. So to introduction, so this is the second commonest degenerative neurological disorders. You will want to understand what degenerative means. You know, a patient comes to you who has very well diabetes, hypertension, next day coming with a left-sided weakness. You know, this is a vascular event. So vascular event is one of the etiologies. But when it comes to neurodegenerative means, with the time, with the aging, your number of cells in the brain, the central nervous and the peripheral nervous system declines, goes down. To start with many billions, maybe around the 40s, 50s, it starts to go down. So because of such, certain actions, certain activities which brain does also get affected. So this is the neurodegenerate, that what degenerative means. So at the onset, you should know that's something progressive. So importantly, what you need to know, what is the first degenerative condition which you know of for the news? This is the second commonest. First one is dementia, most likely Alzheimer's. So prevalence is around, we don't have studies here, which we are trying to do in the future. The prevalence, worldwide prevalence studies shows the prevalence is around 1%. So importantly, you know, the population is around 22 million. So roughly we have about 220,000 to 200 to 250,000 patients in this country. I don't know whether we have diagnosed those enough. The important message is not that. Very recently, about a couple of years ago, the WFN stands for World Federation of Neurology predicts the numbers are going to be doubled in 2025. We are not so far away. It's about in a couple of years' time. So that means we may be roughly handling 500,000 patients at a given time from next year onwards. So usually then we are reaching there, it's not going to so around. At the moment, I would say about in this country, there are about 300 to 400,000 patients, which is going to reach around 500 according to the predictions. Importantly, this mainly affects elderly. As the neurodegeneration, as I mentioned, it goes, the number of cells decline with the age. So it's not surprising the patients are quite elderly. Most of the patients, I would say about 2/3 of these patients, onset of symptoms is after 50 years mostly. But having said it though, we at the moment frequently actually fair number of patients with a young onset patient. Actually at the moment I recently did a small study on myself. I have about in my clinics and in my private sector about almost 500 to 600 patients with me at the moment managing. Out of them about 10 to 15 of them are between 35 and 50. So it's not a disease of elderly at the moment, even at the young. So this is the main thing I want to say. It's a condition which is getting more and more in the future, so which we have to be ready. That's why I initially told, are we doing enough? So if you go to the history, the first description of this the Parkinsonism or Parkinson's disease, I would say in this case, was first described in 1817. That is about nearly 200 and 5 years ago, right? So in this, if you can see, this is the original article which was there in the journal. If you can see, even these features, they described actually 6 patients. Out of them, for Dr. James Parkinson's, out of the 6 patients, he physically have examined only 2 patients. The rest was his diagnosed from his balcony. So you have to read this one. So even all these features except 1 or 2 is just valid for today. That's why the diagnosis you could made in 1817, it's 205 years ago. It's named as shaking palsy, and this was paralysis agitans, but we today in the context we know it's not paralysis we are discussing with. But see the description it made: involuntary tremulous motion. So very important, any movement disorders for that matter, not only on Parkinson's, it involuntary. So that word is still valid even today. With lessened muscle power. So this is one of the major features we described today also. Please, so they mention paralysis, you have to understand it, lessened muscle power, right? The important thing in parts, not in action. What they mention is rest. You know, most of the Parkinson patient has a rest tremor. So rest in action even when supported, right? Sometimes it comes with when the part of the body is supported down. With a propensity to bend the trunk forward. You know, very advanced, this is not true for the young or the early Parkinson's days. When they get go ahead with the disease, they have very stoop postures, which very clearly, and to pass from walking to running pace, they are carrying the hesitancy and the freezing of gait. The sense and intellects being uninjured. That means they are saying that cognition is spared. But today's context, we know, especially in the advanced Parkinson's, not true. But what I want to mention here is, even in 1817, that is 205 years ago, they diagnosed. Did they have MRI at that time? Did they have CTs? Did they have very sophisticated serum biomarkers? None. But at that time also they would have diagnosed. So if you are not in a position to diagnose disease at this stage, it's a shame on us. So that's what I want to mention. So even 200 years ago, this was diagnosed. So that is the message I want to give, and giving all the credits to Dr. James Parkinson. So bit of pathophysiology just for the interest's sake. You know, this is the disease, as you have mentioned, in neurodegeneration. The cells which secrete dopamine, we call nigrostriatal cells in the brain. There is a thing called here, if you can see, the inclusion, Lewy bodies, that's the intracellular inclusion body, they go and damage the cells which is the basal ganglia. As a result, what can happen? So in your right hand side you could see here, if you could see, part of the brain very nicely stained. This is the dopaminergic secretion cells, if you can see the arrow, very nicely stained, what we call substantia nigra. So these are normal person on above. What can you see in the patients in the brain biopsy of a Parkinson's patient post-mortem biopsy? You could see any stains here, you could see. So this is all the cells which secrete dopamine, which is an essential neurotransmitter for most of our activities, is lacking here. So this is the basic pathophysiology. So dopamine is just secreting, nigrostriatal cell is lost. So this is the basic pathophysiology. So severity, what we have found, severity directly related to nigrostriatal cell loss, which is 10 times. If your patient is 60 years of age, if you say a normal person who doesn't have Parkinson's, and a patient with Parkinson's, they say the number of cells, the loss is about 10 times in a patient with Parkinson's. So the disease starts when the cell loss is around 30%. So that's called pars compacta is the area. At times of a first motor syndrome, whichever it may be, right? So with the disease, within another 5 years, they lose about another 20% and goes about 50% cell loss. So that is a very rapid progression after thing. So what they have identified now with the research is these neuronal cell loss begins about 5 to 10 years before the first motor symptoms, minimum of 5 to 10. What is the importance of here? The importance is that most research are now trying to carry on whether we can diagnose before the disease comes. Maybe the patients who has a relatives with Parkinson's or something, what we call pre-symptomatic biomarkers. A lot of research is going on, but so unfortunate we haven't found a good biomarker at the moment. So this is the thing. So, you know, in the diabetes, you can guess this is pre-diabetic or some stage and do some actions to delay the progression, delay the onset of the true illness. We are trying, but what I want to give this message here is the disease starts about 10 years before 5 to 10 years before the symptoms. There is a pre-symptomatic stage. So in this slide, you don't need to go through. This is what I saw. There's a pre-symptomatic stage, as you could see. Then the 30% cell is the early or mild disease here. And finally, as you know, moderate to severe. This is the 30% is the first motor symptom, whatever it is. The figure down shows if the patient gets the first symptoms at the age of 50, the disease onset around 20 years back. There are a lot of symptoms they have identified, actually anosmia. A lot of symptoms related to the gastrointestinal tract has been correlated later into the, but those features are very nice. For an example, they have found now anosmia, Loss of smell is one of the early features even coming from the motor symptoms. And constipation, a lot of other things. Sleep, like REM sleep, RBD, REM sleep behavior disorders are quite common. So here the clinical onset another 20 years. So for an example, if a patient is diagnosed at the age of 50, his condition initially begins around 30. That's why now we are coming across a lot of patients at the early stage, and maximum I would say around 20 years of the survival in a patient. So what's the key feature here? Please, this is the message one I do. The key is the diagnosis at early stage, somewhere around here, at least here. No point in diagnosing at this stage because you have lost almost 3 to 5 years of patients' good quality life because you haven't interacted. We have day-to-day seen a lot of patients which haven't been diagnosed properly. Either they have diagnosed or not managing properly. So because of that, most important thing, the message I want to give you to you is key is to manage at very early stage around this area. So when it comes to diagnosis, I emphasize it again with the literature I showed you in 1817, entirely clinical. You don't need any investigation, but you need to have your brain. Unfortunately, that is what is missing these days in many people. So entirely clinical. Please take this message. You don't need any investigation to diagnose Parkinsonism. So various guideline exist. I will be a very simplified thing. The most important, as I mentioned previously, is to diagnose at a very early stage or when the condition has a very mild disease. So what is the definition? Definition is, as I mentioned, is a neurological condition, not anything else. Neurological syndrome, you know syndrome what means in our medical students, it's a collection of signs and symptoms. Very simple, right? Neurological syndrome manifested by any combination, which I mentioned 4 clinical signs here mainly, independent. For an example, tremor doesn't necessarily be with rigidity, though these are independent and they don't need to overlap either, right? So they are independent, non-overlapping. These are the very cardinal, very core features of motor, as you very correctly mentioned. All these features which I mentioned, they are related to the motor system of the nervous system, not sensory or autonomic. They do have a partnership later in the disease, but when it comes to the diagnosis, what is most important is to rely on these things. Though again, it's a neurological syndrome, which combination, whatever the combination of these 4 symptoms, they are not related to each other. These symptoms, they might have both, and important thing, this is mostly to the motor features. So it's very easy. There are 4 things. Tremor at rest. I'm sure all of you know what a tremor is. Tremor is a rhythmic oscillation around a part of the body. Very rhythmic, right? So it's a rhythmic tremor at rest. Rigidity, it's extrapyramidal. This is not spasticity, I mean. There are 2 different spasticity. Resistant to your passive movement, that is a different thing. Rigidity is like cogwheel, right? So this is when you move the joint around very passively. It's what you feel some cogwheeling, that is rigidity, right? So 2 different terms. This called, actually the correct term should be bradykinesia. To fit into this mnemonic, we have put akinesia. Kinesia in Greek, the movements. Kinesia is movement. Brady is less. So less movement, so slow movements is what you use bradykinesia. The correct term should be the bradykinesia, but to fit into this we call akinesia. Then the postural instability. How does the postural instability present? Patients with falls. They can't turn, right? So those are the things that is important. So this mnemonic is very easy to remember. TRAP. So T for tremor at rest, R for rigidity, which is extrapyramidal cogwheel type of, akinesia, which is, or the bradykinesia. The correct term would be, though I put for the fit into the mnemonic, bradykinesia and postural instability. So any combination of those, sometimes the patient might only have a tremor at rest. So these are the 4 features. I think very, very easy. I think even just a basic examination should entertain these things, should be able to elicit all these signs that I am mentioning, right? I will explain what it is in the videos coming. So this is simply a rest tremor means. If you can think about the patients, right hand mainly, very much typical. Rest is the part of the body is resting. So it's not against gravity. The gravity is eliminated as the hand is kept on the things. Now when the gravity is there, it's not there, right? But in a very advanced, little bit advanced, they have the same thing. I'll show you the video again. It's very typical. It's something called as a pill rolling also, like Veda Mahatya does the pill rolling, right? A lot of quacks around, right? So this you can see, right? So very simple. If you can see this, if a patient comes with this feature, that is the rest tremor, my message today is, unless otherwise proven, it is Parkinsonism. Take that message. If you get that message enough today, that's more than enough for me, right? So again, so this is a rest tremor. When the part of the body is resting, gravity eliminated, you have a very rhythmic movement in the right hand. And the left is also there, but it is little less. Okay, I'll go to the next slide. So this is rest tremor. That's the first clinical feature I showed you, right? Okay. Right. So what is bradykinesia? Now, please mind you that I showed you a video at the onset, right, to see diagnosis. So just keep in mind on this. So unfortunately, I can't raise hands and ask today, but yes. So this is the bradykinesia. See what the patient has a tremor already. So what I am doing here, what we call as repetitive movements. You can see the same movement I ask the patient to repeat. So see whether do yourself and see whether it's yours or you also have Parkinson's, right? So it's here. This is not normal. You have to see, right? So this is not paralysis either. That's what I think you have to know. This is not paralysis either. I have asked three things I have asked to do here. If you can remember the three things. Again, I'll show you the video while describing. One thing we called as this is called opening and closing. Asked to open and close. See what happens. It starts with good little bit of a pace. As the time goes, it's reduce the amplitude and the velocity both. Amplitude is the amount or the peak, right? But it's also reduced. The velocity is the number which is, so both reduces. This is not weakness. This is what we call as bradykinesia. Here you can see then there are three maneuvers we usually do the upper limbs, opening and closing, pronation and supination, and with the index and the thumb we ask for finger taps. Ask the patient to tap fingers. So this is, this is opening and closing. This pronation, and you can see now as goes it blocks. Patient can't do and it goes off the repetitive movement. And these taps is very very specific of such here. So if you can see the right hand is more on the right. It's very clear. Can you see when it starts? It's a movement is much better, but when the time goes, it's become. So this is what we call as bradykinesia. Please take these messages correctly, these technical terms. So what you need to do, ask the patient to repeat the same movement for about 10 seconds and 10 or maybe 30 seconds and see, you will very clearly see the velocity and amplitude goes down. The next is the rigidity. Simple, you can't show in a video, I'm just demonstrating how you are doing it. You have to feel it, there is a cogwheel, even you can see that it's not the normal. This is not spasticity, right? When you move around a joint, you can feel, the person can feel there is some cogwheeling or rhythmic, the resistance to your movements, right? So please remember I told you three clinical signs so far. The first thing I showed you was the rest tremor. Second one is the bradykinesia. Third one I showed was the rigidity, which you need to elicit. I can't show what it is. This is how you demonstrate then. Right. So the next is the postural instability. One of the important things which are late finding, not in the early disease. Don't wait till this stage comes to diagnose. You see how this walking. You can see on the left hand, even the arm swinging is not there. Try to see, this is not a normal person who turns. This is called turn hesitancy. They hesitate to turn, right? This is called turn hesitancy, this clinical sign. Now the patient want to turn and go back, but that also the patient called initiation hesitancy. All these are related to balance issues. Like you move to right, move to more log, so-called moving a log. Right? Very stepwise is not the normal person, right? Right. See this one. This is a very advanced Parkinson, what we call as the initial James Parkinson, very stoop posture, right? See how the patient is walking. Very stoop posture, very slow. If you can see, the left hand is not moving at all. And see whether what happened when patient want to turn. This is called turn hesitancy, and you can sometimes call the freezing also, right? It's not. So very slow. So this is a typical gait of a Parkinson's patient, right? Please don't wait till this level to diagnose, right? Simple, that's the message I want to give, right? But I want to show the clinical signs here, that's what I showed. So now I have showed in the previous video, I had showed the rest tremor. I have showed you what is bradykinesia means, what is the rigidity, how you extrapyramidal, how do you demonstrate, and the postural issues, right? Okay. Right. So far did I mention the word Parkinson's disease? No. What I told you so far is last 10 or 15 minutes. The definition of Parkinsonism. Please take this mind. You think all the patient is coming with this as Parkinson's. It's not. So once you confirm the Parkinsonism, important thing is to find these features which I mentioned. Maybe all four might not be there. Most 99% all four features might not be there except in advanced disease. So then your thing is to why this patient has Parkinsonism, right? So there are four basic etiologies. One thing is the primary, or what we call as idiopathic Parkinson's disease, which we day to day see, right? So which is we see, because most of the patients, especially elderly patients coming with Parkinsonism, idiopathic is there. We haven't found a secondary cause for this because of primary idiopathic Parkinson's disease. We shortly term it IPD. So next important is secondary causes. There are a lot of causes, especially these days. We have seen a lot of drug-induced Parkinsonism. One of the commonest thing, as you might be knowing, our psychiatric colleagues are very much responsible for this one, psychotics. Antipsychotics is a very important. So how do you differentiate between primary and secondary is mostly primary Parkinsonism or idiopathic Parkinsonism at the early stage, they are mostly unilateral or asymmetrical. When it comes to secondary Parkinsonism, drug-induced Parkinsonism, it is usually symmetrical. I didn't go to it. But important message when it comes, you have to have a drug list of drugs. I have to mention two things because our members or our friends do a lot of clinics. I have seen in the clinic books, I have recently diagnosed a lot of patients come in secondary Parkinsonism, prolonged use of flunarizine and stemetil. So don't do this. I know with the patient numbers we try to repeat it. Don't do this because I have seen many patients who started migraine coming with flunarizine, maybe 5-6 years into that, developing drug-induced Parkinson. Unfortunate situation when it comes to drug-induced Parkinson, it's very difficult to reverse and it's mostly lifelong. So that is important. Then comes the third variety, is what we call atypical Parkinson's disease. Is a brother or a younger brother of idiopathic Parkinson's disease. How it differs is its progression is very rapid. You know the term Parkinson's plus, we call it as. There are 4 main conditions which I come to across. Atypical Parkinson's, little bit. What happens is certain the symptoms comes early in the atypical Parkinson. I'll explain what it is, right? Then the hereditary, which is genetic Parkinson's. The commonest is, it's a crime if you miss a patient, young patient around 50, 60 with Parkinsonism, like conditions like Wilson's disease. So never miss Wilson's disease patient come with Parkinson's, because in today's context it's curable. So you should not miss something. If a young patient come with the symptoms I mentioned you, so degenerative. So again, I'll show these are the 4 causes. First, you need to identify whether this patient has Parkinsonism or not. Next is the identify these things. These 4 etiologies could be idiopathic, which is the majority. Always look at any drugs responsible. Atypical Parkinson's, I'll come to a slide in about a couple of minutes time. Then the hereditary. So this is I told you that the diagnosis. Now you know at this moment, at this level, you know what are the symptoms of Parkinsonism. Then is what we call as how do you diagnose, whether 1 symptom is enough, whereas 2 symptoms enough. So this is the easiest. There are a lot of the criterias which helps or guidelines. So I told you 6 symptoms are there, right? Here instead of 4, there is another 2 added. Tremor at rest, bradykinesia, rigidity, posture, which I mentioned. Freezing I have shown, especially in the last video, who was the elderly gentleman. When he want to move another, he freezes. That is one. And flex posture, which I already have shown in my videos, all 6 clinical features. So diagnose Parkinsonism. No need, you need to have 2 of the features where one should be either rest tremor or bradykinesia. Out of these 6 features, if a patient's at bradykinesia, slowness plus rigidity, that confirms Parkinson's, definite Parkinson. The patient has a tremor at rest and the patient has freezing, so it's diagnosed Parkinson. So definite Parkinsonism, you need to have tremor at rest or bradykinesia plus another feature. So what is becomes the probable, either 1 or 2 alone is sufficient. So because what I again mentioned, these 2 features, 1 or 2, the core features of Parkinsonism in one of the guidelines, they so the bradykinesia should be a must, but doesn't matter with this one. Tremor, if the patient comes at tremor at rest, that is unless otherwise proven it is Parkinsonism. That's what I told, right? The patient has bradykinesia, it's Parkinsonism. It's most likely probable Parkinsonism. So please keep it in mind. Possible is features 1 to 2 doesn't need to be there, 3 to 6, that is possible. For an example, especially the vascular and other secondary Parkinson, they present with postural instability, freezing and nothing. So the message here is look for tremor at rest, demonstrate bradykinesia. If one of those things are there, definitely the Parkinsonism you have to suspect. If that is associated with features 3 to 4, 3 to 6, that is Parkinson. So simply, don't ask for the MRIs, don't ask for CTs, nothing is necessary when you want to diagnose. But that is the message I want to. I have seen in medical warning referrals and other things, they have to do MRIs and nothing, but haven't diagnosed this. You don't need. Please understand this concept. Okay, this is just to show you, once you diagnose the Parkinson's, there is a staging important. That is, staging is always to communicate. If I write to another physician or another physician, this patient and HNY staging. So if you know the stage 3 is this, stage 5, so that is, you don't need to go to this extent, but there is staging systems also depending. For an example, advanced Parkinson's 4 to 5. So usually in the early PD, they are unilateral or bilateral or mostly unilateral, very mild symptoms, but 3 is moderate. Unfortunately, what I want to say the message is, we rarely diagnose at this context. So this is what you want to know, right? Okay. So staging is just important, but you don't need to stage the patient, but your diagnosis don't miss a diagnosis. So I told you in the etiologies, atypical Parkinsonian syndromes, right? There are 4 you need to know just for your interest sake, especially if registrars are joining, that's for them. Registrars are joining or postgraduate training. There are 4 we are looking. The one thing is, progressive supranuclear palsy. Those terms we call as Steele, Richardson, Olszewski, if you can remember. So this is the important thing is, but I'll show the common features for these also. All these 4 conditions, the progressive supranuclear palsy, multiple system atrophy, corticobasal syndrome we call it, we don't call it as corticobasal degeneration these days, diffuse Lewy body disease. What is important to identify? These 4 conditions have Parkinsonism, right? That's why they come under the umbrella of the Parkinsonism. But important thing is, it differs from idiopathic Parkinson's for various reasons. One thing is the idiopathic Parkinson very slowly progressive disease, but these conditions are rapidly progressive, right? Patient might, and secondly, early onset dementia. If a patient comes with advanced disease, that's what I told in the James Parkinson, though he told the intellect is not affected, but it's not. Now we know the intellect is the dementia, psychosis, those things come. If the patient comes with Parkinsonism symptoms and very early stage, if you have dementia or hallucination, it mostly falls into the diffuse Lewy body disease rather than Parkinson's, idiopathic Parkinson. These all is to differentiate from idiopathic, right? If an early onset loss of balance and width falls, most likely fit into either progressive supranuclear palsy or MSA, what's called multisystem atrophy. Early and prominent autonomic signs like urinary incontinence, orthostatic hypotension, those symptoms are more in favor of multiple system atrophy, MSA we call it as. Upper motor neuron signs are usually with vascular Parkinson, though I haven't mentioned here. Ataxia, dysmetria and other cerebellar signs, usually in idiopathic we don't see it, especially at early stage. If they are, you have to think about laterally and think it could be one of the things like MSA. For abnormal eye signs, especially the vertical gaze palsy, if the patient comes with an patient to climb stairs, he falls with the early stage, usually are dealing with a PSP or what we call as progressive supranuclear palsy. And most important things, idiopathic Parkinson's disease patients respond very well to levodopa. That is, I'll explain why. These conditions doesn't respond to levodopa, especially at the early stage. So now you know what Parkinson's is, and secondly, I hope you all know how to diagnose Parkinson's, which is very entirely clinical. Now we'll go next to the management aspects. So when it comes to therapeutic principles, always this, not only this for Parkinson's, for even other diseases, some of the diseases, neurological disease comes into play, always give prior to any therapies, maybe drugs or devices or surgery, whatever it is, that have been established as protective. What protective means? It slows the progression of the disease. For an example, multiple sclerosis, we see interferon, the biologicals reduce the progression. Even in Parkinson's, give prior to any therapies that have been established as protective. So unfortunate, so far, many billions of dollars have been pumped into research. We have still not come to a drug which is protective. That is important. That is, even we diagnose at an early stage, sometimes there are no shit. Selagelin was investigated heavily, one of the antivirals. Selagelin was investigated heavily, but unfortunately, still there is no sufficient data to say there is a neuroprotective agent. Then most importantly, encourage patients remain active and mobile. When our Archie or C have been diagnosed of Parkinson's, all the family goes, don't walk, don't stay, be in the bed like that. This is not the message I want to give. Encourage patients remain active and mobile as far as possible, as much as possible, right? Assess the risk of falls. And this is very important message, because today's context, people go and Google the Parkinson's disease, what they say is the Muhammad Ali's video, which is, he was its terminal stage. Is after 14 years or 15 years of diagnosis. Then say, oh my God, he can't walk. So never do that, because now it's been studied, active mobility in the early stage, actually it's a neuroprotective. Now there are studies, but not in the guidelines. Then. So encourage all patients who are diagnosed, give a proper assessment of balance and other things. Patients remain active and mobile as much as possible. That's a message. Third thing is to keep the patient functioning independently. Don't go and feed him. Don't go and do all of his activities on your own. I know that is the situation in this country, right? Being the what we call extended families and more common in our part of the world. So they do everything. Don't do this. This is something harmful to the patients. So keep the patient functioning independently as long as possible. Finally, individualized therapy. What I mean is individualized is, you can't treat a patient who is a farmer at Capiticola same as a bank executive in Colombo. So you have to identify patient needs, lot of other factors which I'll come across. So you have to take each and every patient at an individual basis and offer the treatment and other things. That is a message. Like if you take, when you diagnose fasting blood sugar 140, start metformin to each and every patient, which you could do, right, whether correct or not. But it is not here. So you have to individualize therapy. That are the very basic principles of Parkinson's management. So when it comes to management of, in any condition for that matter, you have non-pharmacological, pharmacological and surgical management options. Here in the Parkinson's all it applies. So there are non-pharmacological like rehabilitation, lot of physios, occupation therapy aspects, speech and other things, which is non-pharmacological. I'll show how important it is. Then comes the pharmacological, neuroprotective. I already told you there is no drug so far, but then what comes under the drugs is symptomatic management. So far all the medicine we have here in this country, even in this world, even the world at the moment, is symptomatic management only. And surgical. Fortunately, there is surgical management for Parkinson's. Unfortunately, we don't have it here, but you should have heard what we call a deep brain stimulation is something which is very, very effective treatment for carefully selected patient in the things. So again, in a nutshell, all these three aspects, non-pharmacological, pharmacological and surgical, is there as an armamentarium to manage Parkinson's, but non-pharmacological we have to explore more, which is available, which we are not utilizing sufficient enough, and definitely we have symptomatic pharmacological treatment in this country. So when it comes to pharmacotherapy, it's simple to identify. If you can, that's why I put the pathophysiology at the beginning. I told you what is the problem with this one. The dopamine secreting cells in the brain, the nigrostriatal cell is lost. So the basis is there is no enough dopamine in the system. So what is the treatment then? You have to give the dopamine from outside, or if there is anything left in the system, utilize them maximally. That's what you need to do. For that actually, so if you did this is a synapse, dopamine has to be released and go into the dopamine receptors. So what you need, so dopamine is broken out by what we call as catechol O methyl transferase inhibitor. So if you can inhibit this metabolism, right, you can the effective level of dopamine can be increased the body. So one of the pharmacological method is give a COMT inhibitor, or the other one is you give levodopa. If the levodopa is less in the body, give levodopa as a drug. So that is one of the things. Then there are certain molecules which act similar to dopamine, what we call as dopamine agonist. So you can use them as treatment. And finally, if there is anything being left in the system, right? You say I told you 30% is lost at the initial symptoms, and then there is rapid progression. If you can remember initially, if there is any dopamine left, so certain drugs like MAO-B inhibitor, that's why they were called as the neuroprotective studies were there on these, like selagilin, resagilin. So preserves any existing dopamine being disturbed or destructed in the body. So these are the four basic things, very simple. If I put into two things, give levodopa from outside, which is either levodopa replaces dopamine, levodopa what we call as, or dopamine agonist. Or the other way around, whatever the dopamine available in the system, make them maximally being utilized. So those are the two pharmacotherapeutic principles. So these are the various groups of drugs, as you know. So the most important thing is what I want to mention is the levodopa, which is called dopamine precursors. That is the mainstay of treatment, levodopa with carbidopa, because carbidopa is when you take it orally, this being again broken down in the body by dopa decarboxylase. So it's being stopped by carbidopa. So IR means there are a lot of preparations, immediate release, continuous release, dissolvable tablets in mouths, lot of things, but doesn't matter that. But I want to mention the commonest drug is levodopa, that has to be utilized very effectively. Then the dopa carbidopa, usually the levodopa comes with the levodopa doesn't come alone in preparation, they comes in a preparation as levodopa carbidopa combination, or levodopa benzoyl which is called MADOPA, right, then dopamine agonist as usual, which acts similar to dopamine. Those are the things. You can go, I'm not going to detail, but otherwise you will, this becomes a pharmacological lecture. I'm not going to do this. What I need to mention is the thing is somehow increase the level of dopamine in the body. That is the things. There are a lot of armamentarium, lot of arms we can use for such. So the next important question when it comes to diagnose Parkinson's, what medications to start? That is very important question, because this is where we are lacking in those things. Being a neurologist and being interested in movement disorder, I will start something else. A physician or internal medicine person will start something else. General practitioner might start something else. But most important thing, you have to be guided by certain principles. So therefore, many factors help in determining which drug should be the first line medication. So what are the factors that is responsible? Age and overall health of the patient. So you are not going to manage a patient with 45 years of the Parkinson's patient as diagnosed Parkinson's at 45 years as a 70 years of age. So that differs. I'll show you why. Then concern, because the problem with the dopamine or levodopa preparations is they are more prone to develop what we call as motor complications, right, in the due course of the disease as the disease progresses. So you have to somehow delay the progression or delay the onset of motor the complications, which I show in a video later, right? So concern for development of motor complications. Third thing is other comorbidities, whether the patient's dementia, then you have to certain drugs which will be helpful for dementia. Orthostatic hypotension, you have to be careful, certain drugs might worsen. For an example, dopamine agonist might worsen the orthostatic hypotension. The patient has sleep disorder, sometimes drugs like amantadine might worsen if the patient has insomnia, it might worsen. So you have to be careful of the other comorbidities. Finally, in this country, most of the important cost of the medication. That is also a factor, that's why I mentioned. So that's why in the given example, a farm from Kabithikollava from Ajanta's region might have problems, but not from the person from Colombo, right? So we have to be very cost of the medication. At the moment, if you can remember about 6 months ago, if you are doing in a medical clinic and none of the medications are available in the country to treat even a levodopa. So the cost of the medication is very, very important when you are treating. There's no point in writing down 10 tablets the patient can't afford. So you have to, that's why they're very important to discuss. So these are the factors which needs to assess before starting an medication to this one. So symptomatic treatment, early disease is the concept. Those days we were mentioning, you did not start treatment at all. Sometimes some schools of thoughts was start treatment early as possible. So I am giving certain facts. As if you can remember now at the moment, I told you at the moment what is available even in the over the world is symptomatic treatment only. That you have to remind. So for an example, these are the factors. Patients sometimes no need of necessarily. For an example, I had a patient who was an electrical engineer came to me about 5 years ago. So he told me, I have a very slightest tremor when I get a little bit agitated or when I'm in a meetings or something, and I examine, he has very, very mild Parkinson. I explained everything and told, is there anything affecting you? Is your work affected? No, I'm fine. I do everything. So I offered him all the things and I told, shall we observe? Yes, he agreed. You won't believe, so he was 3 years, he didn't take any medications, right? That's what I told, none of the drugs are non-neuroprotective. So therefore, no need to start initially. So if the patient is symptomatic, his day-to-day activity is affected, his occupation is affected, then definitely you need to start symptomatic treatment. For patients, do not necessarily, that should be a discussion between the person who is being affected and the physician. So early treatment does a better job, but there are a lot of studies, if the patient has even the slightest activities, with the slightest nature, the patient's activities are affected. For an example, the businessman might come and tell you, because of this tremor, my signature is now changing. So it's definitely you need to treat this patient. Otherwise, he'll be chased away and he'll be a lot of embarrassment in the bank. So because of such, even early treatment does a better job of maintaining quality of life. That's what I mentioned, quality of life, than delayed treatment. So that is why you have to discuss with the patient, take good 5-10 minutes with the patient. You have this diagnosis, explain the diagnosis. You are not going to die on the next day, you have to and give the options to them. Thirdly, many factors help in deciding in initiation of symptomatic therapy in the early days, which I showed you in the before side, the patient's age, other comorbidities, patient level of activity and cost. And what this symptomatic treatment does is improves the quality and ability to continue his work. If you can remember, I told one of the basic principles is the patient should be active and mobile. So if that drug helps him to do that, you have to treat, right? Then reduce disability and find attitude toward medications. You have to give this. So when the patient tells this is going to start anti-Parkinson medicine, they are going to be hanged, right? Some feel. So you have to carefully discuss with the patient. This is very, very important. Otherwise, patient defaults treatment because some of these drugs have a little bit of a side effects as well. So if you continue, levodopa is out of the medications I mentioned you as it's not no wonder here because levodopa is deficient in the system. So if you want to treat, you have to give levodopa. So levodopa is the most effective symptomatic treatment. No argument on that. Everywhere in the world is the most effective symptomatic treatment. So long-term use, unfortunately long-term use increase the risk of motor complications, especially in young onset patients. Therefore, we try to delay the onset of drugs after discussing with the patient. Dopamine agonists, that is second class, which drugs which act similar to dopamine, right? Those called dopamine agonists provide good symptomatic control, but never even closer to the levodopa. So the first line is levodopa. Second line is the dopamine agonist. The drugs which are available, you all know. Pramipexole is one thing. Other one is what we call as the ropinirole. Those are the dopamine agonists available in this country. So delays onset motor complication, but more prone to cause intolerable side effects, especially in early. Especially in the elderly, you have to be very careful when starting treatment. Especially dopamine agonist. The last sentence refer to dopamine agonists. They are more prone to get orthostatic. When they get up in the morning, they might fall and fracture the femur. So very careful. So in starting treatment. And somnolence, some drugs cause a lot of drowsiness, especially the dopamine agonists. And cognitive decline. Sometimes in other countries, a big issue. They have some sort of what we call sleep attacks. While driving, they sleep and get accidents with the dopamine agonist. So you have to be very careful of. You have to explain each and everything. Otherwise, you will be sued in other countries. So you have to know the adverse effect profile. So what I want to mention here, there are two main drugs available: levodopa and the dopamine agonist. But still, the levodopa is the best. Especially for younger patients, better to start with a dopamine agonist. I will show you. So this is what I call dyskinesia. So this is very dreadful complication, right, due to the levodopa. So to avoid such in a young patients, we try to delay the onset, but at a given time you might have to start. It's a coriform movement, you can see. It's a coriform movement, very arrhythmic, the patient is very disabled, right? This is one of the common motor complications of levodopa, right? So dyskinesia is further subdivided into dose or peak dose of endodose. Don't need to go to that level, right? So this is one of the, what you have to know this one, right? Okay. So now again I am coming to the many initial treatment considerations. So as I very correctly mentioned, no definite neuroprotective therapy in a young patient mean below the 50 years of age, I say. Minimize long-term dyskinesia effect, which I showed you. Otherwise, in 5 years' time, they might develop the dyskinesia I showed. So because of that, dopamine agonist, pramipexole, ropinirole is better. I would say not recommended, better early onset disease, because the disease is also very mild at the onset. Older patients, maybe 60 or 70, to the dopamine agonist causes a lot of cognitive effects. Because of such, levodopa is the mainstay for them as the first line. Patients with very mild symptoms, non-dopamine medications, though amantadine and other things might help, but these are very, very expensive. In this country, it's not available in the public system. Amantadine will cost about 200-300 rupees per tablet. Selagelin is almost more than that. So, though I mentioned for interest sake, this is not possible in this country at a general level, but these two are yes. So, you have to little consider. Okay, now what I am going to show you here, this is a patient from Kurunagal. Show this patient, I want to say how levodopa helps in a patient's symptomatic management. See this video. It's a very young onset Parkinson's. If you have seen this patient, so you can see the rostrum, don't you, right? Asymmetrical or maybe unilateral. The face you can see expressionless bradykinetic face, right? You can see it's not laughing at all. It's very logical mask-like face, right? Very. Can you see the bradykinesia here? Very much less, right? Okay, that's why repetitive movements. Yeah, there are motor blocks we call as when you go there are blocks. Yes. So this is before. Here you can see on the left side. And comparative to the right side, both are slow but very bradykinetic. Okay, so just observe the next slide just after a dose of levodopa, right? Right, okay, now you can see is active, right? In fact, we use these as a levodopa challenge test also when we have bit doubt of the patients, right? Okay. Now you can see. So the face is more expressive, right? Isn't it? So the expressions are coming. It's basically laughing now, little bit of a smile. So what I have done here, I have given a dose of levodopa. I think maybe half or 1 tablet of levodopa. 250 is a tablet. See here, it's not optimal though, right? So you can optimize the treatment, but what I want to show you, what we call the levodopa response does. It is about after 1 hour of giving the treatment. Can you see it's much more less bradykinetic? Here. Symptoms were worse on the left, if you could remember, but it's much more better now, right? Much better. So this is why I told you the levodopa is the treatment of choice. Okay, I'll stop from there. Let's balance and other things, you don't need to go there, right? Okay, now I'm coming back to the first slide I showed you. I'm sure, who says this has Parkinson's? If so, why? Oh, my God. So what I'm showing here, the bradykinesia, if you can remember, right? So this is slow, right? Here, so motor blocks. I'm sure you should be able to see at least these probable Parkinson's at the moment. He had a rest tremor, if you can see in the beginning, in the left hand, you just see. If you have missed the diagnosis first, I think at the end of the lecture now, you should be able to diagnose this one, right? That is the message I want to give you, right? Right, okay. If you knew these Parkinson, and if you have described why is what, if you knew that, that is more than enough. I think you should have gone out without being there in the lecture, right? Okay. Okay, now I am going to show you in how the rehabilitation helps. Just watch this video. So some people say everything is drugs, which is not. Especially in advanced Parkinson, it does wonder. So this patient now, if you can see, can't walk. This is what we call as freezing. Balance is gone, right? Can you see? Now see what happens with the rehabilitation. Now he can ride a bicycle, right? This is what helps in a, yeah, this is the doctor who did that research. In all shows here. Now he rides a bicycle. So this is not due to the drugs, because this is very advanced Parkinson's. When it comes to advanced Parkinson's, use of drugs actually causes side effects more than the benefit. So it's more harm than benefit. Now he goes on a ride with another friend also. Here. Now the same, this is another patient, right? With the rehabilitation, with the input from the multidisciplinary teams. Yeah. Cycling, and these are very important exercises patients should do, right? See how the patient who was not able to even, always keeps his with the therapist. So what he described, the sound is not there, how he has improved with this one. So now what you need to do is, especially in the advanced disease, not advanced even, I am saying very early disease, most important, introduce for therapy, right? That is very important, exercise and other things here. And dancing, the group dancing had been a very good, the group therapy. Actually, when I was a SR, I started at National Hospital those days with Madam, my boss, Professor Anjani Gamage. There's a group therapy for patients. So this is the message I want to give. All these things, it is available in the most of the places there are therapists. You have to have a discussion and start a rehabilitation clinic, right? Okay. So what are the take-home messages? I am coming to the end of the talk. Parkinsonism is common. You might not think that is common. It's very common. And out of that, idiopathic Parkinson's remains the commonest. I have underlined it's undiagnosed. That is why I am saying we are not doing enough. These are very simple diagnosis if you know the subjects. If undiagnosed, especially in the early and mild disease. Diagnosed entirely clinical, no need of any investigations. So that is, you have to understand. No medication proven to be neuroprotective, which slows down the progression, unfortunately, might come in the future. All medications which I have showed you so far are symptomatic only, right? Levodopa remains the main pharmacological agent, but dopamine agonist also has an important role in the management. So combination plays an important role in managing the patients with improved quality of life. Management should be individualized. That's the other message I want to give, and patient-centered, considering various factors which I already told you. I think that's all. Thank you very much for your hearing. Hope you got something, right? Yes.
Thank you, sir, for that very interesting and very informative lecture. And I think it was very simple and easy to understand. And we have received 3 questions so far. The first one is, do we need neurologist opinion to confirm diagnosis of Parkinson?
Hope you posted that question before I did the lecture, right? Isn't it? So I told no need. But if you are in doubt, but I always tell, when you diagnose for Parkinson, not. If a patient comes with tremor, which is at rest, you can easily diagnose. As I showed you other clinical signs now, the bradykinesia and rest, the rigidity, which you can do it elicit, If those things are there, it's very clear the diagnosis can be made at your level, at your GP center. But as you mentioned, the neurologist, it's always better to refer and confirm the diagnosis, not because of the diagnosis. Sometimes there may be atypical features, which I didn't go into length. The other important thing is to what management strategies you could offer. For that reason, I always recommend to get the neurologist opinion at the first, and then you can manage. Maybe neurologists need not to see each and every visit, maybe every 6 months, every 1 year. Sometimes my patients are there, I see them only in 6 months or 1 year times, because no. So in a nutshell, no need to refer to a neurologist to diagnose, but for further management and other things, better get an opinion.
Thank you, sir. And the second question is, if we suspect Parkinsonism or early symptoms of the disease, but not the cardinal symptoms, what should we need to do?
Sorry, can I?
If we suspect Parkinsonism but not the cardinal symptoms, what should we do?
No, I think I have very clearly mentioned in the talk what are the cardinal symptoms. So to diagnose Parkinson, those things should be there. What are those? Rest tremor, bradykinesia, rigidity, postural instability. And in addition, I told, which is related to the motor blocks, the freezing of gait and the hesitancy, which I showed you already. So to diagnose Parkinson, these features should be there. And out of them, if you are very lucky enough to have rest tremors and bradykinesia, then definitely it's Parkinson with some other features. So it's very clinical. I don't think if you know the cardinal features, that is Parkinson. There is nothing called non-cardinal features of Parkinsonism. So diagnose Parkinsonism first, then think about the etiological, like atypical, secondary, like neurodegenerative, like young patients or other things. But for diagnose Parkinson, all are cardinal. There is nothing called non-cardinal. So simple answer is all cardinal features.
Thank you, sir. And the third question is, dear sir, could you kindly explain how to get rehabilitation facilities in Sri Lanka? This is from my father. Thank you.
Okay, thank you. Yeah, something which we haven't explored enough. That's what I showed you in the last video. If you can see, this is very much we need to explore. Unfortunately, when we send the patients to Parkinson, even when I send the patients to physios and occupation, they do what we call as stroke rehabilitation. So this is something which we are lacking in the system. So if a good physio, it's a multidisciplinary team. The physio alone do, the occupation therapies alone can't do. So it should be a combination or multi-call as in neurology, but so not only on Parkinson's, it should be a multidisciplinary approach. So in this country, there are certain centers, especially under the neurologists. For an example, Ragama we do have, Colombo I think we have, certain centers where are neurologists, there are rehabilitation. Otherwise, no point in just sending a patient to physio and do Parkinson's rehab. They don't know what to do, right? For an example, freezing of gait, they have what we call Q training, right? Q training. The therapist doesn't know what is Q training means, no point in sending. They do something adverse which might have an adverse effect on the patient. So therefore, I don't know from where are you, the important thing is to get in a touch with a neurologist who knows the subject and then think about a proper physio program. That is the most important thing. Don't just send, otherwise if the therapist doesn't know about the subject, that's going to be a disaster in the way. Sometimes it's not better to do rehab if they don't know, right? So it's always a multidisciplinary approach for rehabilitation.
Thank you very much, and we have completed all the questions now. And thank you, sir, for joining us today, and thank you for all the participants for joining us and sending us questions. Have a good day.